السلام عليكم وكل سنة وانتم طيبين. Thank you for inviting me for this interesting meeting, and I hope we will conclude with some interesting discussions. My special thanks to Professor Maha. And when we discussed the topic for this presentation, I chosen in particular the topic of SGLT2 inhibitor and diabetes. And probably most of my colleagues share the same opinion of the importance of diabetes as a risk factor of multiple comorbidities, mortalities, and as we all know that around 30 to 50% of our dialysis populations are diabetics, and around 30 to 40% of diabetic populations, they develop some form of chronic kidney disease, and they are at a high risk of mortality. We will see from the next few slides how the diabetes could affect the mortality and what are the prevalence and the growing incidence of diabetes in the following few years. As we know, and I've mentioned already, that diabetic kidney disease develops in 30% of type 1 and 40% of type 2. Around maybe 450 million globally have got diabetes, and the projected figures by 2040 will be 642 million. You can see here from the ranking of the different causes of mortality in 2016, and diabetes occupies the position of 15 and chronic kidney disease 16, and these positions will jump to around position 5 and 7 as the cause of mortality by 2040. You can see the incidence of and the prevalence of diabetes in the Middle East area will double from 2017, when it is 40 million, to be around 80 million by 2045, doubling the figures. And in Egypt in particular, we have got around maybe 15% of the adult population have got diabetes. 40% of them are not diagnosed. Many of the pre-diabetes are undetected. And more important than that, the growing figures for type 2 diabetes in the Egyptians from 2007 to 2013 has grown from 4 million to around 7 million, and is expected to be 13 million by 2035. So 13 million out of these 80 million. As you can see, this is the figures of type 2 diabetes in Egypt. And this is, as I mentioned, 50% of the adults, they have got diabetes. Some selected governorates in Egypt consistent with the same figure, where it is around 16% in Alexandria, around 21% in Sohag, and probably it is all coincident with the same figures nationally. 40% of the Egyptian diabetics may be undiagnosed, and the number grown from 4 to 7.5 in 7 years, and then expected to be 13 million by 2035. As you can see, the number of diabetics globally and locally is getting worse and worse. You can see the diabetes as a cause of death here. I mean, all-cause mortality when you got diabetic kidney disease, the hazard ratio is around 3.1 compared to any other type of death related to the cardiovascular, stroke, diabetes, or kidney disease. But diabetes alone, if you consider it as a cause of death, it's around will be 22% on those patients in the diabetics, and on those with only CKD without diabetes, doubled the hazard ratio. But if you combine the chronic kidney disease with diabetes, it will be around 50% of deaths amongst these population will be because of diabetic kidney disease. So as you can see how significant is the impact of diabetic kidney disease as a cause of mortality. There are certain risk factors that we need to consider, which are the level of EGFR and the proteinuria. And with the reduction of the EGFR and the presence of the CKD, you can see that the diabetic kidney disease doubled the risk of mortality from 1.4 to around 3. And if you consider the proteinuria as a risk factor, you will see the presence of proteinuria in a diabetic kidney disease, again, will double the risk of mortality compared to the chronic kidney disease only. So it is very clear that the risk of drop of the EGFR and the proteinuria carries a significant increase in the risk of mortality in diabetic kidney disease patient. Again, the level of proteinuria is a significant risk factor, as we know, as a cause of progression of chronic kidney disease, not only progression of chronic kidney disease, but as a cause of mortality. And as you can see here, for a certain level of EGFR, increasing the level of the proteinuria, you can see increasing the hazard ratio of mortality. And that's why we usually use the EGFR or the slope of the EGFR and the proteinuria level as an indicators or surrogate signs of worsening kidney function and probably cardiovascular disease and mortality. You can see here the worst of the life expectancy loss would be for those patients with the diabetic kidney disease compared to diabetes only or CKD only or the general population, where the patient at 30 years old for a male loses around maybe 16 years compared to around 17 years for a female at the same age. There are many other risk factors could be considered for susceptibility or initiation or progression of diabetic kidney disease, but the most important one that could be modified are the hyperglycemia, the obesity, hypertension, and the proteinuria. And we have got many of the clinical trials concentrated on these 4 risk factors. And we will discuss here the albuminuria in particular and why we have chosen the SGLT2 inhibitors in this regard. Since the landmark trials of the 2002 by Brenner et al. And Lewis et al. For the RAS inhibition, we didn't have any breakthrough for the disease progression prevention for diabetic kidney disease up until the SGLT2 inhibitor trials. So for around maybe 20 years, we didn't have any breakthrough. Since the RENAL study and IDNT study, you can see that RAS inhibition using the angiotensin receptor blocker in the renal losartan has reduced the progression of the chronic kidney disease by around 0.8 mils per minute per year of the EGFR. This is the one for the losartan group, and this is the one for the placebo group. And you can see that the risk of the end-stage renal disease is reduced by around 28%. And the risk of reducing the proteinuria is in favor of the RAS inhibition with the losartan, and the reduction has been around 30%. There was a comparable result with the IDNT when they compared the irbesartan with the amlodipine and the placebo. And you can see that when you use the irbesartan, the rate of drop of the creatinine clearance was around 5.5 mils per minute per year compared to 6.8 mils per minute per year for the placebo versus 6.5 mils per minute per year for the amlodipine group. So you are saving around maybe 1.3 mils per minute per year in favor of the irbesartan. And the same risk in terms of the proteinuria. I mean, the proteinuria has improved by around 1.1 gram reduction per 24 hour with the irbesartan group, compared to minus 0.1 in terms of the placebo and plus 0.3 for the amlodipine group per 24-hour equivalent. And the risk of reduction of the end-stage renal disease was around, again, 22% to 26%. Now, The story of the SGLT2 inhibitor started from the 19th century when we have the herbal medicine fluorescein, very well known to cause glucosuria, but it was not known how it exerts its effect or what is the mechanism of action of the fluorescein. We know that the fluorescein comes from the bark of the apple tree, the extract of the bark of the apple tree, and we were unable to use the fluorescein as a glucosuric simply because it has non-selective inhibition of the SGLT2 receptor, because it inhibits both SGLT2 and 1. And SGLT1 particularly abundant in the gastrointestinal tract. That's why the fluorescein has got a lot of side effects, particularly the diarrhea, by inhibiting the gastrointestinal receptors and inhibiting the glucose reabsorption. Also, one of the active metabolites of the fluorescein can cause a lot of the side effects. That's why they've stopped using the fluorescein, but they start to clone the genes for the SGLT2 receptor 1 and 2 in 1990s until they have approved the 3 famous molecules from the SGLT2 inhibitor, specifically for the SGLT2 inhibitor, because simply the SGLT2 occupies around maybe 90% from the reabsorbing capacity in the proximal convoluted tubule, but the SGLT1 contributes by around only 10%. The canagliflozin approved by the FDA in 2013, and the DABA and the IMBA in 2014. And the story of the development of these molecules, very interesting, because when it started as a hypoglycemic agent, although it doesn't cause any hypoglycemia. So they started to think about might improve the glycemic control. But as it needs good glomerular filtration rate to do the effect of the glucose reabsorption and sodium reabsorption, then with the reduction of the EGFR, there is an attenuation of the glucosuric effect of these molecules. That's why the licensing, initial licensing for by the FDA as glycemic control drugs, it was for those with the EGFR more than 45, because the glycemic effect below EGFR 45 is negligible. But when they have done the major clinical trials, the initial ones, the IMBA-REG outcome trial, the DECLARE-TIMI with the dapagliflozin, and the CANVAS program, they realized that it improved the cardiovascular outcome, not only the glycemic control. And subset group of those patients, when they analyzed it, they found it improves also the proteinuria. That's why they have done a specific trial for those patients with the chronic kidney disease or diabetic kidney disease with proteinuria to examine the renal outcome. And this came in the CREDENCE trial, and they found some patients with the, diabetic and little proteinuria in the heart failure trial, like the DABA-HIF. They found that they exert, improvement of the renal outcome. And they thought that it might be the mechanism of action is not reliant only on the improvement of the diabetes control and the renal progression. It might be all cases of chronic kidney disease simply because of the increased intraglomerular pressure in all cases of chronic kidney disease because of death of many of the glomeruli, and the only surviving glomeruli has got increased intraglomerular pressure, and might be the mechanism of action of the SGLT2 receptor, which is proposed to modulate the intraglomerular pressure by increasing the delivery of the sodium to the distal tubule and the macula densa, enhancing the vasoconstriction of the afferent arteriole, thereby reducing the intraglomerular pressure. As we can see here, the main mechanism of action of these molecules is just to inhibit the SGLT2 inhibitor, mainly this receptor, and it will release the glucose and the sodium into the tubular lumen. And this, all the consequences of the glucosuria and the natriuresis will be the cardiovascular and will be the better renal prognosis. And this is the tubuloglomerular feedback by increasing the delivery of the sodium to the distal convoluted tubule, to the macula densa, enhancing the vasoconstriction of the afferent arteriole, reducing the intraglomerular pressure, enhancing all the better or the good renal prognostic signs. So as we can see here from the cardio-renal effects of the SGLT2 inhibitor, for the renal, increase the natriuresis, and that's why it reduces the intraglomerular pressure with afferent vasoconstriction, reduced ischemia reperfusion injury, even of the acute kidney injury cases, because you are reducing the oxygen demand by inhibiting the work of this receptor and reducing the oxygen demand of the inhibited receptors. So the hypoxia injury will be minimized. For the cardiovascular effects, mainly through the natriuresis, so reducing the blood pressure with the average reduction of the blood pressure is around maybe 3 to 4 millimeter mercury for the systolic. Also the metabolic effects coming from reducing the HbA1c or the weight reduction, and all these collectively will bring up the favorable cardiovascular effects of the SGLT2 inhibitors. Now, coming to the recommendation, I would like you to just remember the number of 25 here. Why I'm saying that? Simply because we are dividing those patients into patients with eGFR more than or equal 25 ml per minute, which is the cutoff for the inclusion criteria for the DIABETIC trial, and also albuminuria of more than 25 milligram per millimole, which again, the cutoff of the DIABETIC trial when they recruited the minimum of 200 milligram per gram of albuminuria. Why I'm saying these numbers? Simply because if you have got a diabetic patient who is proteinuric with the eGFR more than 25 ml per minute and has got albuminuria of more than 25 milligram per millimole, it is recommended to initiate him or her on SGLT2 inhibitor. And when I say recommended, because there are two, it's 1A grade. And we have got, I mean, just to remember these numbers, I mean, you have got the quality, which is A, B, C, D, and the level of evidence, which is only 2, 1 or 2. 1, when you have got the risk benefit ratio, is very clear that the benefit outweigh the risk. And the number 2, it means that the risk and the benefit is ambiguous and might be equal. And that's why for level 2, we say suggest, but for level 1, we say recommend. But A, B, C, D, A for the well-designed randomized control trial, B, which is the quality of evidence, B, trial, which might suffer from flaws and some problems in the design of the trials. C, when it is relied the evidence on observational studies, and D, when it is an expert opinion or case reports. So for a patient who has got proteinuric type 2 diabetes with eGFR more than 25 and albuminuria more than 25, it is recommended, and the evidence is 1A, particularly if has got established coronary artery disease or symptomatic heart failure, irrespective of the ejection fraction. I'm saying irrespective of the ejection fraction because the recommendation in the past was for those with reduced ejection fraction, but most of the CKD population has got structural problem, and usually their heart failure is with preserved ejection fraction. And we have got now the IMBA preserved heart failure trial, which reconfirmed the same finding like the IMBA reduced ejection fraction heart failure trial. So it is regardless of the ejection fraction and with established coronary artery disease, type 2 diabetes, with the eGFR more than 25, albuminuria more than 25, you should, or we recommend to start the patient on SGLT2 inhibitor unless there is a contraindication, which we will come to it shortly. If you have got a patient who is non-diabetic with urine ACR more than 25 milligram a day, we recommend to start him on the SGLT2, one of the SGLT2 inhibitor. And I'm saying by non-diabetic, it's a chronic kidney disease, still with EGFR more than 25 mL, but the cause of the chronic kidney disease is not diabetic, not polycystic kidney disease, not one of the glomerulonephritis, which has been treated with some of immunosuppression, like the lupus nephritis or like the vasculitis, ANCA-positive vasculitis. So if you have got a patient who is hypertensive, IgA nephropathy, with the albuminuria more than 25 milligram per millimole, and the EGFR more than 25 mL per minute, we recommend to start him on one of the SGLT2 inhibitor. If you have got the patient with the proteinuria less than 25 milligram, and his EGFR still more than 25, we suggest, not recommend, and the level of evidence to be, to start him on one of the SGLT2 inhibitors, simply because we don't have enough evidence to say that non-proteinuric, diabetic, chronic kidney disease patient might benefit from the SGLT2 inhibitor as yet. And the EMBA kidney trial, which will report probably by the end of 2022, will answer this question, because many of them, they have albuminuria less than 25 milligram per millimole. We said that patients without diabetes who with the CKD due to any other cause other than the polycystic kidney disease or any other immunological disorder like the vasculitis or lupus nephritis, and any patient with heart failure with EGFR more than 25 mL per minute, regardless of the proteinuria, regardless of the level of the ejection fraction, he can benefit from the initiation of the SGLT2 inhibitor because of the beneficial hemodynamic effect of this class of medication. Might be some practical points here. When we are saying about the SGLT2 inhibitor, any of them will do the same effect because the outcome of the trials was reproducible in the three, whether it is EMBA, DABA, or CANA. And the dose, it is the smallest dose. I mean by the smallest dose, for dapagliflozin 10 milligram, for empagliflozin 10, not the 25, for the canagliflozin, it is the 100 milligram, not the 300 milligram. And when you use this SGLT2 inhibitor, you can see that most of the patients recruited in these trials have been using the RAS inhibition. Don't forget, the RAS inhibition can reduce the progression of EGFR drop by around 1 mL per minute per year. Compared to the SGLT2 inhibitors, might be you will add another 2 mL per minute per year improvement by the SGLT2 inhibitor. So you are making more improvement of the renal prognosis and the renal outcome by reducing the proteinuria, by retarding the progression of the chronic kidney disease. But don't forget that the RAS inhibition, they will work by a completely different mechanism. So the SGLT2 inhibitor, the vasoconstricted the afferent arteriole, reducing the intraglomerular pressure. The RAS inhibition, they vasodilate the efferent arteriole, reducing the intraglomerular pressure. When we are talking about these things, we need to make sure that if you have got albuminuria, you don't rely on a single reading unless the urine ACR more than 70 milligram per millimole. If you have got single reading of more than 70 milligram per millimole, it's acceptable to rely on it and you can initiate the SGLT2 inhibitor. But if you have got less than 70, because it is very variable to have the urine ACR during the day, during the night, if you have got, say, for example, a lot of protein intake, if you have got, say, for example, dehydrated or a lot of the hydration exercises, it can make a lot of changes in the urine ACR. So if it is 70 or more, you can rely single reading. If it is less than 70, you need to be having at least 2 readings to confirm the level of more than 25 milligram per millimole. You don't rely on the dipstick of the albuminuria. You don't rely on the urine PCR to initiate the SGLT2 inhibitor, just the urine ACR. And finally, if you started the patient on SGLT2 inhibitor and his kidney function deteriorated to the level of renal replacement therapy, including dialysis, whichever the form of dialysis or transplantation, the patient can carry on at the very low level of the EGFR up to the level of starting dialysis. Once they start dialysis, because they don't have any EGFR, which means that they don't have any ultrafiltrate or very minimal ultrafiltrate, so the mechanism of action theoretically of this class will not be there, because there will not be a reabsorption of the glucose in these circumstances, or natriuresis. Obviously, if you would like to use the MRA, which is the mineralocorticoid receptor agonist like spironolactone or finerenone, you can use them safely, although we don't have specifically in these trials used the mineralocorticoid, but we assume that using the MRA with the RAS inhibition, there was no problem except the hyperkalemia. And the same here with the SGLT2 inhibitor, we are not expecting to have any problem using them. And that's why the level of evidence is 2B. What are the special side effects of the SGLT2 inhibitor you have to be careful about? It is obviously the euglycemic diabetic ketoacidosis, and that's why we don't recommend this class of medication for type 1 diabetes or any patient who is at risk of developing diabetic ketoacidosis. And those patients who are the elderly, who are doing any ketogenic diet, that's why we don't recommend at all any patient who is receiving SGLT2 inhibitor to have a ketogenic diet. Those who are on diuretics, those who are fasting, if I've got any alcoholic liver disease or excess alcohol intake, has got an ongoing infection, has got HbA1c very high at the beginning of, say, for example, 86 millimole per mole, which is 10% of HbA1c, or those who require the insulin very quickly after the diagnosis of diabetes. For example, within a year from the diagnosis, they are at high risk of developing diabetic ketoacidosis, and I should be very careful if I am describing for them or prescribing the SGLT2 inhibitor. Those with the underweight, with the BMI of less than 27, again, at a high risk of developing euglycemic diabetic ketoacidosis. As we can see here in this table, those are the patients who are at risk of developing diabetic ketoacidosis, and I should be very careful when I'm using the SGLT2 inhibitors in them. What about the hypoglycemia? It is mainly when you are using the insulin and when you are using the sulfonylurea or meglitide. I mean, why is that? Simply because when you are using the insulin, you need to reduce the insulin dose by around 20%. When you are using the sulfonylurea or meglitide, you need to reduce the dose of meglitide or the sulfonylurea by around 50%. When you are doing that, particularly if the EGFR more than 45 mL per minute, because the hypoglycemic effect or the glucosuric effect of this class will be high or intensified, and it will be less and attenuated if it is less than 45 mL per minute. And when the HbA1c will tightly controlled less than 58, those are the two risk or the three risk factors to develop hypoglycemia. If the HbA1c is less than 58 millimole per mole and the EGFR is more than 45 mL per minute, and the patient is on insulin or sulfonylurea or meglitide. Obviously, if he is on DPP4 inhibitors or GLP-1 receptor agonist or glitazones or metformin, they don't need those adjustments, even with the low EGFR. And obviously, we don't use the metformin with the low EGFR anyway. The AKI and hypovolemia, we have to be very careful about the hypovolemia if the patient is on diuretics or an elderly patient. And don't forget the AKI risk is reduced with the use of the SGLT2 inhibitor because of the ischemia reperfusion risk reduction with the reduced demand for because of the hypoxia. The most important point is that when you initiate the SGLT2 inhibitor, because of reduction of the intraglomerular pressure and vasoconstriction of the afferent arteriole, it is expected to have a drop of the EGFR by around 5 mL per minute. And this drop will be sustained, and after that there will be a progressive improvement. You expect this drop by around maybe 3 months. After that, if you compare it to the placebo or any other medication, you will find those who are on SGLT2 inhibitor will do better. After, say, for example, 12 to 18 months, you can see the separation of the curves on the clinical trials. I don't think that we need to do any assessment of the kidney function after initiating this class of medication, as we do with the RAS inhibition. We don't ask the patient to repeat the use and ease at any time point, but unless there is any evidence of acute kidney injury due to any other cause. Patients with peripheral vascular disease are at a high risk of having amputation, and if you are using the SGLT2 inhibitor, the mechanism is unclear, and we have to be very careful for those who have got high risk to develop any peripheral vascular disease or leg ulcers or peripheral neuropathy, or have got previous history of amputation. It is recommended to counsel this patient, and if they developed foot ulcer during the treatment, you might need to suspend them and to restart them if it is highly indicated because of the risk of amputation. Mycotic genital infection, particularly for the diabetic patients, and this is very understandable, particular for the female patients. This is very understandable simply because of the content of glucosuria in the urine. If the patient has got recurrent mycotic infection, you might initiate anti-mycotic whilst he is having or whilst she is having SGLT2 inhibitor. Special groups, there are two special groups. The transplant, we don't have any evidence for those who have got functioning kidney transplant patient to initiate SGLT2 inhibitor because we don't have any evidence of the efficacy or safety, particularly the urinary tract infection. And also for patients with type 1 diabetes, as I mentioned, we need to be very careful. And in case you started the type 1 diabetes patient on SGLT2 inhibitor, it would be preferable by the diabetes team, and they should have some monitoring for the ketone bodies. And if it is more than 0.6 or he developed any symptoms suggestive of diabetic ketoacidosis, to suspend this medication straight away. We'll go quickly about the two most important clinical trials for the renal patients and renal outcome, which are the CREDENCE and DIABETIC. As you can see, the eGFR average inclusion was average of 56, the mean was 56 mL per minute, and the minimum level was 30 mL per minute. But for DIABETIC, the minimum was 25 mL per minute, and that's why we are saying that if you have got a proteinuria diabetic patients with eGFR more than 25, you can initiate it. 50% of the patient have cardiovascular disease. All the major clinical trials initially, the ones I mentioned, the DECLARE-TIMI and the MBARIG and the Canvas program, all of them, they have got some form of coronary artery disease before the start. 5% of the patient has got a history of amputation. Despite of that, the risk of amputation in this trial was very minimal compared to the placebo. 15% of the patient has heart failure, and nearly 100% they have been on RAS inhibition, and 2/3 have been on insulin treatment. And as you can see, the outcome, the HbA1c dropped only by around 0.25%. As you can see, it is very, not sizable improvement of the glycemic control. And obviously the improvement of the HbA1c will be far better with the higher HbA1c on the start and with the higher eGFR. Systolic blood pressure is reduced by around 3.3 millimeters mercury, and the body weight reduced by around 0.8 kilos. Albuminuria reduced by around 32%, which is comparable to the RAS inhibition. As you can see here, the curves of both the eGFR drop. In the placebo group, sustained drop all throughout, and in the canagliflozin as initial dip within the first 3 months, then sustained, and at the end it is improvement compared to the placebo group, and the separation of the curves apparent by 18 months. You can see some effect. The rate of drop of the eGFR with the placebo was 4.59 mL per minute per year. For the canagliflozin was around 1.85 mL per minute per year. Be careful here that those patients or this trial, as well as the DIABETIC, has been terminated by the drug monitoring committee simply because the patient achieved the efficacy point, and there is no reason, and ethically is not ethical to carry on with a beneficial trial and to deny those who are on the placebo the benefit of this medication. That's why they have stopped it earlier before they completed it. And this one stopped at around 2.6 years, and the other one, which is the DIABETIC, around 2.4 years. And the proteinuria, as you can see, the separation after 6 months, and the drop was around 32%, around 300 milligram per gram, which is around maybe 25 to 30 milligram per millimole. The reduction of the end-stage renal disease was around by 32% of the canagliflozin compared to the placebo group. And the renal outcome, which is the renal death, dialysis, or kidney transplantation, or doubling of serum creatinine, was reduced by around 28% in the canagliflozin group compared to the placebo group. And this is a similar effect for the DABA-CKD, despite of the DABA-CKD has got around 32% of their population were non-diabetic. Okay, chronic kidney disease mainly due to hypertension or IgA nephropathy. What are the most important complications? Acute kidney injury was in favor of the canagliflozin as the hazard ratio was 0.85. And the amputation again was comparable in both group, placebo and the active treatment. And the diabetic ketoacidosis, as you can see, around 11 times compared to the canagliflozin compared to the placebo group. Cardiovascular death definitely was better in the canagliflozin group compared to the placebo group, but you have to be very careful that the cardiovascular mortality has improved by around 30%, reduced by around 30% in the SGLT2 inhibitors, and mostly attributed to the heart failure outcome, not to the MACE outcome, because the MACE outcome is around 10% improvement, but the heart failure outcome is around maybe 40% improvement. Thank you.